Hey, Don here. Welcome to Podiatry Practice Mastery, where we're going to help you get to the $1,000,000 mark and beyond. For those that haven't downloaded it yet, I put a lot of time recently into my $1,000,000 practice blueprint. It's basically a kind of a recording videos of how kind of we work to get to the $1,000,000 mark. If you haven't looked at that yet, I would go to Podiatry Practice Mastery and just look at that, download it. Put a lot of time into it. I think it would help you. If you have any questions about like implementing anything, I think knowledge is easy, but then implementation can kind of be a challenge. So I'm going to go over. This is a recording for a Wednesday in my office. So this is a newer office, so it's a little bit slower. So I always like to say the good, bad, and the ugly. So I think this day I had 5 patients in the morning, and then 6 in the afternoon. And then I had a few add-ons. I think I had about 3 add-ons. And then the benefit to this is, I don't know if you're maybe in a space where you have some time some days. And I have one of my other colleagues that I just basically shadowed him for some time. And I always get amazed when I shadow someone else of how they do things. My partner here, Neil, he is a very, very good clinician, very good communicator with patients. And there's certain things I think I would do different as I kind of explain things, but I can't negate just how much quality, like analogies that he uses in explanation and empathy and care and things like that. So if you do have time to visit and chat with other doctors that are in your office or even other doctors in the community, I think this is one of the things that's really helped me the most. Then you can kind of pick those things. Now, this isn't something that's just done, in my opinion, as like a resident or a fellow. It's something that can be done because you can always learn something, either what to do or what not to do with other doctors. So I was just really amazed, and I'm going to grab a few new things that he does. Okay, let's go into the day here. First patient here. This is a patient who had a new fracture. Patient new fracture code. I think the main thing today we're doing these fracture codes. So this was a fracture of a second metatarsal. Next patient was a 82-year-old. She has a really painful first MPJ, and I did a cortisone injection to that joint. Now, she came in directly for the cortisone injection, and so in those cases, I don't tend to do an office visit unless I'm talking about other things. Like if they come in just for the cortisone, a lot of times I'm just doing the cortisone. Next patient was a patient. He had second met pain, and he had a fracture of the second met. And this gentleman, he is a mountain, like an Appalachian mountain guide. And this, if anything, this would be my MVP of the day. So Appalachian mountain guide, second metatarsal head fracture, pain with vibration. He wants to get out and hike because like this is his prime hiking time. And I said, hey, you can give it time to get better, which is really you're looking at 6 to 8 weeks wearing the boot, or we can try to speed this up with Shockwave. And so he is one that all day long wanted to start the Shockwave. I didn't do it today because he was he just took anti-inflammatories, but we're going to start him. Now, when I do Shockwave, for people that are really in a hurry, I give them 2 options. I'm going to explain this. So usually for fractures, I'm doing 4 sessions. I guess you could do 6, but usually I'm doing 4 for fractures, okay, to speed up the healing. You can either do it weekly, or if people are really in a hurry, I do them actually every 72 hours. So every 3 days, you can do it. It just gets the treatments in quicker, and I guess theoretically, the 72-hour time, it just works a little bit quicker to get them back. I did the weekly ones recently for a fibular fracture, and she was out of her boot in about 4 to 5 weeks. And so I think the return to activity, the reduced swelling, and things like that. So I think this would be the best one. He's setting up these 4 Shockwaves. I don't know if he's going to do every 3 days or every 7 days. I think 7 days works easier in my schedule, but for some patients that are really in a rush, they'll do these that way. Okay. So this would be really the MVP patient of the day. Next patient was a patient that came back in for a tinea. So I did a biopsy of the skin. So 2 2-millimeter punch biopsies came back. He did have tinea pedis. And for this guy, he also had onychomycosis. So I told him, I said, you can do just the the topical like ketoconazole, or you can do the oral medication that'll take care of the skin and the nails. And so he opted for that. So I went over, I pulled out my fungal nail treatment sheet. Once again, if you don't have that, shoot me an email, down at podiatrypracticemastery.com. I'll send you mine. But it basically goes over how he gets the terbinafine, the LFTs, the UV light, the shoe spray, everything else like that. So he did that. Next patient was a matrix follow-up. Now this was a funky, this is like a 3-week matrix follow-up, but he had a really, really bad, ugly nail ingrown with a lot of like fissuring at the tip of the skin. So once we took out this nail, like everything has gotten better for this guy, his toenail. Next patient also was a second, third MPJ pain patient after meloxicam for a possible ultrasound. She did not need any of that. She is feeling so much better. So just an office visit and no follow-up. Next patient was a 55-year-old. She had an MRI follow-up, and she had an OCD that was noted in her talus. And so I talked to her either about doing Shockwave to help with the bone marrow edema around that area, or possible surgical repair. So I sent her over to one of my colleagues that does a lot more of these OCD things. So I sent that to Dr. Saviet in my group. So I don't know if he's going to do the procedure, or if he's going to do Shockwave. Next patient was a 67-year-old gentleman. We had an MRI in for him as well. He ended up having a really bad first MPJ arthritis, but he also had some big cysts in that med head. And so I discussed with him about either like doing some bone graft in there and fusing the joint, or doing cortisone injection. Now this gentleman, like I said, he's not that old, but it's just really debilitating him. So to start, he wanted to do a cortisone injection, but I did advise him that he may need some type of surgical repair in the future. Next patient was a 63-year-old female. She had hammer toes, and she had been using a crest pad, a Boudin splint in the past. And she came back in, and so she wanted something a little bit better. Now, she's already wearing LEMS and anatomic shoes, and her toe is still rubbing. So I talked to her, and I modified her correct toes. So I guess one of the benefits of spending time with my buddy is he wears his correct toes. I forgot to put mine on today, but he wears them, and he does a lot of correct toes, explaining kind of how they work and modifying them for patients and things like that. So I modified, so I was like inspired by him, and I modified her correct toes, and she's going to be wearing them instead of just the simple Boudin splint that she was wearing before. Next patient was number 5 out of 6 for Shockwave for the plantar heel pain. He's doing much better. He's got one more set up, but he's already feeling better. And then next patient was a wart removal patient. And so I just kind of scooped that out. This was a 15-year-old female. She is an avid lacrosse player, and just wanted this out versus, I did go over the other treatments, but sometimes for one wart I'll still remove them. Next patient was like a 65-year-old man with gout in his left big toe joint. I got a uric acid on him. I offered him a cortisone injection, but it was too painful. He didn't want that, so I did prednisone for a little bit, and then based on the uric acid exam, I'm going to possibly put him on colchicine. I did not start colchicine at the same. I did prednisone first for him. Next patient was a left third metatarsal fracture, 84-year-old female. Put her in a cam boot, and she has to wait until she feels better. So that was the day. It was a good day. I think the benefit was that fracture and doing the Shockwave. So when I do, let me talk about a little bit more about this focus Shockwave. So when I do fractures, theoretically you only need to do focus Shockwave, but I find if you do radial and focus, the radial can help with all the soft tissue swelling around the tissues, bigger surface area, and then the focus can actually help with the fracture healing to kind of speed up the healing to the fracture site. So I tend to do both, and I do these, like I said, every 72 hours to a week. Okay, hope you guys find that beneficial. Once again, if you haven't got that $1 million practice blueprint, go over there and grab that. Shoot me any questions you have based on this. Thanks. See you tomorrow.